Hello, everyone. My name is Astrid Pavlovsky, and I'm a hematologist in Buenos Aires, Argentina. Now we're going to shortly deal with the treatment of patients older than 60 years old with Hodgkin lymphoma. It is believed that due to the immune dysfunction associated with aging, there's an increase in cancer development. That is what we call immunosenescence. Age is an unfavorable prognostic factor for the treatment of Hodgkin lymphoma, meaning that survival in survival in Hodgkin lymphoma is poor with increased age. It gradually decreases after the age of 50. There may also be a correlation between immunosenescence, frailty, and an intrinsic refractory of this disease, although all of these points are still not well defined. Also, tolerance to therapy is a challenge. Actually, the most important challenge in this group of patients is to cure the disease up front, and there is no universal standard of treatment up front for everyone. ABVD, especially bleomycin, has shown to be toxic for this age group, and many different retrospective studies have shown that ABD can be an acceptable treatment, shown in different publications. Also, a pet-adapted approach can be of great benefit. As new drugs have been approved and shown to have a great efficacy, especially in refractory Hodgkin lymphoma, like brentuximab and checkpoint inhibitors, different treatment strategies have been tested for this group of patients older than 60 years old in first line, either using these new therapies in a concomitant way with chemotherapy or sequential. Single-agent brentuximab vedotin has tested in this group of patients seems not good enough, with the German Hodgkin study group publishing an experience with an unacceptable progression-free survival of 52% at 12 months. An important trial was presented by Andrew Evans in 2018, starting with brentuximab and following with AVD. 75% of the patients actually could finish all of this planned therapy, and this resulted in a 2-year progression-free survival of 52%. In this trial, we see once again the importance of the geriatric assessment to predict prognosis in patients aged older than 60 years old. Regarding the results of the ISHL trial comparing VB plus AVD versus AVVD, a subgroup analysis for patients older than 60 years old did not show a clear benefit for this group of patients, and PFS was lower than for the younger patients, which was around 67%. Further combinations with other novel agents or consolidation with radiotherapy should also be analyzed. We have the results of the Keynote 204 for refractory patients, which compares VV versus pembrolizumab, but still, in patients older than 65 years old, this did not show a significant difference. Other treatment approaches for first line can be the combination of checkpoint inhibitor and AVVD, and we have a different experience with Nivo plus AVVD, either sequentially or in combination, showing a high percentage of remission rate. So maybe here we have a good combination. New studies are still recruiting patients, trying to show which can be the best adequate therapy. Trials with tislelizumab, also as monotherapy or randomized to combining them with AVVD, are still ongoing. This is the INDI trial, so we still need to look for these results. In the US, a trial testing the combination of VB plus Pembro versus VB versus Pembro plus AVD is also recruiting patients. So far, we have lots of new clinical trials, but none of them have entirely solved the problem of treatment of Hodgkin lymphoma in the elderly. We clearly need to have more clinical trials trying to solve the problem of less tolerance to therapy and a more refractory disease in patients older than 60 years old. Thank you very much.